We're going to review the abdominal aorta for ultrasound examination. The abdominal aorta is everything between the diaphragm and the iliac bifurcation. When we scan the abdominal aorta, we're looking for focused pathology, namely the presence or absence of an abdominal aortic aneurysm. When we do the scan, you want to be an abdominal preset. This will help your imaging quality. It will also mean your indicator will be pointed towards the patient's right or their head. In a sagittal plane, the indicator will be pointed towards the patient's head, and you can see there the indicator is pointed towards the patient's head. In a transverse plane, your indicator will be pointed towards the patient's right side. The probes can be used are the curved array or the phased array, either of which can be done on abdominal preset. The curved array will have a larger interface and a higher frequency compared to the phased array. We're going to review some of the key landmarks that you have to identify when you're doing an abdominal aortic scan. The first thing is the spine or the spinal stripe. Next is the aorta itself. You also want to identify the IVC to ensure that you are looking at the aorta and not the IVC when you measure. You want to identify branch points off the aorta, including the celiac axis, the superior mesenteric artery, and the iliac arteries. Key parts of the exam is identifying the aorta. The aorta runs along the spinal column to the left of midline. You can see here on this transverse view, we can see the spinal stripe, identify the vertebral body. That will help you identify the aorta. You are not necessarily looking for the aorta at first, you are looking for the spinal stripe, which will help you identify the aorta. What you'll see is the anterior surface of the spinal column with posterior acoustic shadowing because of the bone. So you can see here on this ultrasound image, we can identify the spinal stripe. That's the anterior surface of the vertebral body with posterior acoustic shadowing because of the bone. Because the spinal stripe is identified there, and we are in a transverse plane, we know on our indicator side that is the patient's right and their left side. That tells us that this vascular structure anterior to the spinal stripe and to the left of midline is the abdominal aorta. When you measure the abdominal aorta, you want to measure the outer wall to outer wall, which means including the edges of the wall. So the first part is to identify the wall itself. We're going to identify the spine right there, and you see the anterior vertebral body. And when you identify the bony process there, you can then identify the posterior wall of the aorta. You can then follow the curve anteriorly to identify the anterior wall. And you can see the circular structure of the aorta there. Using the posterior wall to circle around to the anterior wall helps you identify the anterior wall if there are overlying structures, such as in this image with the veins and arteries nearby. When you measure the aorta, you want to include the wall. Part of this is because if there is mural hematoma in the presence of an abdominal aortic aneurysm, you don't want to just measure the lumen, such as this case, which is a failure. You want to measure the actual aortic aneurysm, which includes the outer wall to outer wall. So let's review some abdominal aortic anatomy. There are three regions to the abdominal aorta. There's the proximal, mid, and distal portion. The proximal portion is from the diaphragm to the branch point of the celiac axis where it takes off from the anterior surface of the aorta. The mid aorta is from the origin of the celiac axis until the SMA takes off and branches. So while the SMA is in view, you are in the mid-aorta. Distal aorta is after the branch points of the SMA until the bifurcation to the iliac arteries. So let's begin with the proximal aorta. Once again, this is from the diaphragmatic origin to the origin of the celiac axis. Many times this is hidden behind the liver. You can view it in the transverse or sagittal planes. When you view it in the transverse planes, you're going to see the aorta and the IVC anterior to the spinal column. You will not see any branch points, and you will also not see any SMA or celiac view. You can see here we have a proximal view of the aorta in a transverse fashion. I can see the spinal stripe. I can see the abdominal aorta measured outer wall to outer wall, and I see mostly liver dominating my view. I do not see any evidence of the celiac axis or the SMA in view. If the celiac branches or the takeoff is in view, you are now in the mid-aorta. Here in this transverse view, I can see the celiac branches. That tells me I have gone distal to the takeoff of the celiac axis. Viewing the proximal aorta at the subxiphoid process can be somewhat difficult because the probe cannot go more proximal as it is inhibited from traveling superiorly by the xiphoid process in the rib cage. When you get this view here, you can see most commonly you'll be seeing the celiac axis. And what you'll see is the celiac axis coming off the aorta with its two branch points. If this is visualized, this is already the mid-aorta as it is distal to the celiac takeoff. And what you want to look for, the common view of the celiac branch points or the celiac trunk with the two branch points forming a little seagull sign. If this is seen, this is already in the mid-aorta. So as you scan through here, you can see the seagull sign, and then you can come proximal to the celiac takeoff to get to the proximal aorta. Many times in the transverse view, you may be already seeing the celiac origin or the branch points. To get above this to the proximal aorta, you'll have to tilt your probe to shoot more superiorly. This represents a problem as when you image the aorta in a transverse portion, you can get a true transverse view and measurement. However, if you have to tilt your probe, you can get an ovoid or a tangential view through the aorta and falsely elongate it or enlarge your measurement. You can see here we have an aorta view where we have a true transverse measurement of the proximal aorta at 2.96 centimeters versus an oblique view that had to be rocked, which gives you a 3.11 centimeter. And this could make the difference between a diagnosis of dilation versus not. What you may have to do for the very proximal aorta is gain a sagittal view with the indicator towards the patient's head where you can see the aorta there. However, this then allows you to rock the probe to image more proximally above the celiac takeoff and behind the liver and more proximal. What this will do is take your aortic view here and it will angle it. Now, this also gives you that tangential view. However, because you have the celiac axis and your branch points, you can now measure the aorta. Be sure when you are measuring, you are not measuring perpendicular to the screen, but perpendicular to the aorta from outer wall to outer wall. Here you can see a view of the proximal aorta in a sagittal plane to gain a view proximal to the celiac takeoff. You can then measure outer wall to outer wall and gain your aortic measurement. The key here though is if you're measuring sagittally, you do want to make sure you're in the midline of the aorta and not off to the side where you may falsely underestimate the size of abdominal aorta. In order to make sure you're in the midline, the things you want to identify are the celiac axis and or the SMA. Seeing these two branch points allow you to view the midline of the aorta for your measurement. You can see here the celiac takeoff is there and the SMA is there. Sometimes they're very close together. If you can see this image, as we scan back and forth through the aorta, we can see the branch point where the SMA and the celiac take off. This allows us to identify the midline of the abdominal aorta in the sagittal view to gain an accurate measurement. The next portion is the mid-aorta, which goes from the celiac takeoff to the SMA origin until the SMA branches into smaller vessels. This can be done in transverse measurements as you do not have the rib cage impairing your probe movement. We're going to obtain transverse views here of the aorta, and you want to get an image with the SMA view. While you can start with the celiac takeoff, this is very close to the proximal aorta, and measuring the anterior wall may be difficult with the branch point there. What you may want to look for is down where you can see the SMA in view. And you can see here the SMA anterior to the aorta. The SMA is known as the mantle clock sign, and you can see this anterior to the aorta. The SMA branches off from the aorta and is surrounded by mesenteric fat, giving it that mantle clock sign. Here you can see the classic appearance of the SMA surrounded by mesenteric fat, making it appear like a mantle clock. There it is anterior to the abdominal aorta. You can also note the splenic vein coming over the SMA. You can also see the left renal vein coming between the SMA and the aorta. And here is where we would measure the aorta, anterior wall to posterior wall, outer wall to outer wall, which gives you your mid-aorta measurement. Here's another view of measuring the mid-aorta, and you can see the SMA view right there as indicated by the arrow. Here we have a sagittal view of the abdominal aorta, and we can measure proximally to the celiac to measure proximal aorta, and we can measure distal to the SMA origin to get our mid-aorta somewhere like here. The distal aorta is from when the SMA branches until the bifurcation of the aorta into the iliac vessels. This can also be done with transverse measurements, and it is ideally done in transverse as you no longer have the SMA to identify the midline of the aorta. So we're going to image in a transverse fashion, indicator towards the patient's right side, and we're going to look for a portion of the aorta where the SMA is no longer in view, but proximal to the iliac bifurcation. And what you can see is the aorta here, and you can see some branch points of the SMA, but not the SMA itself. What you want to look for then is the bifurcation of the abdominal aorta into the iliac arteries. Now, this may occur proximal to the umbilicus. Here we have the SMA coming down and starting to branch into its tributary vessels. However, it is somewhat difficult to identify these branch points in most patients. What may be easier is identifying the abdominal aorta where there is no SMA or branches present, such as here, and we can measure the outer wall to gain an abdominal aortic measurement. You can see some air artifact, and this is likely very close or overlying part of the umbilicus. The other thing you can do, and much easier to identify the distal portion of the distal aorta, is you scan until you see the aorta bifurcate to the iliac vessels. And here you can see the aorta has bifurcated into the right and left iliac arteries. If you come just proximal to that, that would be the end of the distal aorta, and you can measure there. Once again, we see the abdominal aorta branching into the iliac vessels, and we come just proximal to that to measure our distal aorta. And you can see here, once again, outer wall to gain your aortic measurement. You should also perform an overview scan of the aorta. You should also perform an overview scan of the entire abdominal aorta, which is sometimes easier done in the beginning of the scan, where we're going to start at the very proximal aorta. We're going to scan down, see the celiac takeoff, see the SMA branching into its tributary vessels, and then we see the abdominal aorta splitting into the iliacs. This allows us an overview of the abdominal aorta to identify any pathology that we can quickly focus on rather than getting hung up on doing multiple measurements before getting to the area of pathology in an unstable patient. Focused pathology on the abdominal aorta scan is looking for the presence of the abdominal aortic aneurysm. Generally, this is defined as abdominal aorta that is greater than 3 centimeters in diameter. However, the true definition is a vessel that is 1.5 times the proximal segment is size for an aneurysmal dilation. The average adult aorta is 2 centimeters, which is where the 3 centimeter rule of thumb comes from. But the 1.5 times the proximal segment allows you to identify aneurysms of other blood vessels. The average abdominal aorta is 2 centimeters, so a dilation up to 3 centimeters would be greater than 1.5 times the proximal segment, meaning definition for aneurysm. However, if your proximal aorta is only 1 centimeter due to small stature or small size aorta, dilation up to 2 centimeters, while below that 3 centimeter cutoff is twice the size of the proximal segment and is aneurysmal. You can have fusiform aneurysms, or you can have saccular type aneurysm. On average, an abdominal aortic aneurysm can grow 0.3 to 0.4 centimeters per year. Abdominal aortic aneurysms may be classified as small, medium, large, or very large, which carry a difference in the risk of spontaneous rupture. Of note, when measuring the abdominal aorta with ultrasound, the measurements can vary from exam to exam, but should vary less than 5 millimeters between exams. Most abdominal aortic aneurysms do have some disruption of laminar flow. And where blood flow is less than ideal, some of that blood will tend to thrombose, and you'll get mural thrombus forming along the aneurysm. And this can be a normal finding within the pathology of the aneurysm. You can see here another example of mural thrombus. And you can have the lumen, which is why we want to measure outer wall to include the entire aorta and not just the true lumen, excluding the mural thrombus. Once again, you can have a measurement, it's over 3 centimeters and larger than the proximal segment. This is an abdominal aortic aneurysm in a proximal segment. Here we are measuring, we're above 3 centimeters, and this matches an abdominal aortic aneurysm. Here we have a sagittal view where we can see that the aneurysm there is 3.72 centimeters. We can also see that the proximal segment has also started to dilate there, and the distal portion of the aorta narrows again to 2 centimeters. As we scan through this portion of the aorta, we see that we go from abdominal aorta to aneurysm back down to abdominal aorta. You can see here as we scan through this abdominal aorta, we see 2 areas of dilation. We have a proximal and distal area with some mural thrombus. And we have 2 areas of aneurysmal dilation here with the intervening portion of normal sized aorta. Here you have a sagittal view of an abdominal aorta with some tortuosity to it, but you can see a saccular aneurysm where you dilate from 1.87 centimeters to 3 centimeters and narrow back down to 1.8. You want to obtain orthogonal views of any pathology, meaning if you identify something abnormal, you want to visualize it in 2 planes, both the sagittal and the transverse, or views that are 90 degrees to each other. So we can see here that we have the sagittal view of the abdominal aorta with the aneurysmal dilation, which is somewhat hard to visualize. When we move to a transverse view, you can see that aneurysm is much more prominent and much easier seen and measured compared to the sagittal view. That if you do have the pathology, you don't want to visualize it in 2 planes, as you may be able to identify key points of the pathology and certain measurements easier in one plane compared to another. So some key points to remember is scan through the entire abdominal aorta, measure outer wall to outer wall. Proximal is your diaphragm to your celiac origin. Mid aorta has the SMA in view. Distal is proximal to the bifurcation of the aorta into the iliac vessels, and you want to gain 2 views of any abnormality. Don't forget to subscribe on YouTube and follow on Twitter.